Welcome everyone this afternoon to the Lunch and Learn, which is going to be on single point of access, integration care coordination from the navigation access team. So I won't bumble on too much. I think the only thing I want to remind you is there is a feedback survey that that'd be really grateful to get your input for. We're constantly trying to change and tweak these as we go along. Thanks for those people who have, I sent an email to a few people. Thanks for coming back to me on that already. But the feedback survey, we do look at it. We do try and change and move things along with your feedback. So just going to do a quick reminder of that. And then without doubt, I'll hand over to, is it Liz?
Yep. Thanks for that, Lee. Thank you very much, Lisa. That was seamless. So being a Friday, we thought we might need a little bit of motivation for you all. And we did think about doing it as a sing-along session, but maybe that might be pushing the boundaries too much. So instead, we're doing a Menti along. So if you could just log yourselves into Menti, and you'll notice that the first two questions are you sort of settling in questions. So we're going to be asking you how you're feeling today and also what you'd like to get from this session. And then as you go along this session, it will work seamlessly alongside a very talented smorgasbord of presenters that we've got today. So if I can invite you to Menti up, and Lisa, if we can just have a look at the agenda that we've got for today's Lunch and Learn. So obviously we're in the check-in and welcome session. Then Captain Rob Kemp is going to introduce the problem that we're trying to solve with SPOA. Then we're going to go into what it is with Giles. We're going to talk about the importance of clinical conversation with Rob Cole, and then enablers and barriers to Jenny. And then Patrick is going to speak to us about the guidance and documents and stuff that are out there, some principles that we can follow when we're talking to our sites. So let's just have a look and see how everyone's feeling and what they're up to today. So we've got people excited. Oh, there's a lot about the sunshine. So happy days. Are they all northerners? Because apparently it's not as sunny in the south. But yeah, Friday feeling. Anxious as well. I'm hoping that's excited anxiety, or maybe it's one of our presenters and they're worried that this might not be as friendly audience as we had planned. The next slide, if we could. So we've got a good mixture, and thank Crunchier it's Friday. I couldn't agree more. So what we're looking to get out of the session, a bit of an understanding, overview of potential, broader understanding, all of the answers. Yeah, okay, well, I mean, if we're looking for all of the answers, then obviously look no further than Rob Kemp, who's going to do the next section, who's going to set the scene for us. I will hand over to you, Rob. Thank you.
Hi, thanks, Liz. Certainly not a lot of answers here, but a number of questions. And also thanks to the navigation and access team for pulling this together, and thank you anybody that's turned up this afternoon, appreciating it. It's Friday. I'm going to start with the fact that there's a number of myths that have perhaps grown up around care coordination and single points of access over time. And while we don't want to oversimplify this afternoon, we want to distill things down into what might be some handy bite-sized pieces for people to take forward. We're also acutely aware that this perhaps needs to be more mainstream moving forward. It is mentioned in the winter letter. There have been some name changes, and of course the guidance has been recently published. But the principles have endured over the last couple of years with all of those systems that we've worked with, although each one of those does tend to have its own little flavour, and we'll talk about some of the variation and yet, however, the principles linking through despite that variation. You'll notice the Menti, and we think it's important for us to keep in contact with you as we go along this afternoon session. We see your thoughts, ideas, feedback as an essential accompaniment to today's session. So please don't be shy in putting your thoughts down. And we're not after the easy questions, we're after the tough ones as well, so we can respond to this in a way which is meaningful, not only now, but also when we produce more guidance moving forward. I'll start with the problem we're trying to solve. So this is no surprise for us, I think, that systems that are under pressure can be characterized in a number of ways. And when access itself is difficult, patients tend to manifest themselves in the services that are available. So this often means patients will present in the 111, the 999 system, and either indirectly or directly at emergency departments. When these services themselves are overrun, it is typically the patients with the complex needs and those who are, typically the patients with the complex needs are those that are left waiting in the tail end of the systems. So it's these patients in the tail ends of care that we're particularly curious about. And when I say the tail ends of care, I mean those patients waiting for ambulances in the Cat 3 and the Cat 4 queues at home. So what do we know and what don't we know about this piece of work? What we do know is the mortality associated with overcrowding and waits in hospital. What we do not know is the harm, mortality associated with the waits of tails of ambulance response times. So in terms of our understanding of that mortality, it starts when patients arrive at hospital. However, the pot of that harm exists well before those patients arrive at hospital. Pardon me. So single point of access and care coordination provides systems with oversight of these waits. What it also does, and by connecting patients with the right care for their needs, provides a system response for those patients most at risk. So it attempts to apply this with a home first approach typically, but equally attempts to escalate those patients who require it. As a result, and we think this is really important, single point of access and care coordination is not a tool to reduce conveyance, but a clinical response to the unseen, undifferentiated patients who may be at risk. And as a result of waiting, it's also a way of connecting patients with the care as a way of preventing the deterioration that could lead to conveyance and admission. So I'm now going to hand over to Giles to take us through the next bit.
Oh, thank you. Thanks, Rob. So interesting summary slide there, following on. If we wanted to distill what care coordination is in a paragraph, a short one at that, a clinical conversation that safely connects the patient with the right care for their needs, independently of where the patient presents in the system. Wouldn't that be wonderful? So providing healthcare practitioners with an autonomous senior clinician, Rob C is going to talk about that, who takes clinical responsibility to coordinate the most appropriate episode of care by accessing the right services and skills from across the system to reduce the number of steps, handovers, access, inequalities, referrals and waits to deliver better outcomes. So let's dig into that a little bit. I think there's a Menti slide coming up which allows people to ask a few questions, but can we just flick on to, yeah, so, you know, what is, so this is something that you can do in slow time as well. So we don't necessarily, but we can pick some pieces out of this as well as we go along. So it's really interesting for us to understand what people's understanding of what it is and what it isn't. Because that helps to guide us in when we're working with systems and with our own colleagues to see where the blind spots are or where we're really getting it right and we can understand it. So if I start, just for me, you know, what is ICC? I've heard lots of things described to me. Interestingly, on more than one occasion, I've heard people say, "Oh, isn't it the same as the System Control Center, the SCC?" No, that's a different. Not totally unrelated, but that's a way of monitoring performance and activity across a system set up in all different areas. It's not that. It's also not the International Cricket Council, which is disappointing, or the International Criminal Court. So there's been some interesting issues around names recently, and the national team has circled back on single point of access as the defined name. Interesting, on a meeting with Kieran Sundstrom just yesterday, he said he's not precious about what systems call it. It's about what works for them. So if it's already embedded as ICC, integrated care coordination, that's fine. SPOA has a number of different meanings. So I guess a lot of you will have heard of the Clinical Advice Service, or the CAS, which is effectively the system by which 111 and 999 interrogate and provide information to share, to guide and direct people to the right care for them. So this isn't the CAS, however, it can and does, when working really well, function very closely affiliated to the CAS, has some overlaps, but predominantly integrated care coordination is aimed at clinicians and helping clinicians to access the right care for their patients. Now, that's not to say it doesn't overlap. As we've seen in certain areas, Norfolk and Waveney, for example, there is a real overlap of how the CAS bleeds into the ICC and vice versa. But predominantly, the CAS does the patient-facing piece, and SPOA tends to do the healthcare professional and care provider access, as the diagram here shows. And if you look at the bottom line of all the different possible services that exist out there, and that's just the headlines, each one of those might contain multiple areas as well. And if you're a paramedic or a community clinician looking to navigate that, and you've got a different access point for every one of those services, oh my word, that gets difficult. I think it's called Hick's Law, where the more options you've got, the harder it is to make a decision on where to go, which lends itself pushing back towards, well, the point of least resistance could be ED. So if we, rather than going through this, there's a lot of information on that slide. I always like to start, Nick Holding would agree, and others, Simon Sinek fans, about we start with why. Why would we want integrated care coordination? Well, and we labour this point quite a lot. It's about creating a learning and integrated care system. Now, the learning bit's really important, because what it is, it's a system that is able to learn, to adapt and to react to immediate issues and to longer term ones, and produce a better system than sending everyone to the ED. That said, it's not about emergency department avoidance. It's about getting people to the right care at the right time in the right place. So around the why, optimizing clinician and patient contact time, so reducing some of that duplication. We talk about it reducing inequalities. I think this is an area we need to explore, but I feel that if we can provide patients care as near to their home, if not in it, as possible, that starts to reduce inequalities. We know that a higher percentage of those that attend ED are in the highest deprivation deciles. So it's really important that this addresses that, and we need to monitor that. It improves and reduces patient contact points. So less contact points, the better, less handovers, the better, less risk it potentially as a result. And that learning understands how a whole system can develop to have an integrated workforce, and that's quite difficult, but it's starting to be addressed in areas, and it sits in with some of the governance things which I'll mention quickly. So what is it? So at its crux, it allows a clinical conversation independently of where the patient presents, going back to that statement before. Safely connects the patient to the right care for their needs, reduces the number of steps, provides timely access to same-day urgent clinical assessment. And I think what it does when it starts to get really mature, it has the ability to case hold. And the thing about case holding is that's what frees up other clinicians' time. So it's around a system ownership of holding what is inherently the patient's risk, but holding it to enable not necessarily the quickest solution, but the best, most appropriate in the right place solution. Sometimes hurry up and slow down is quite a good mantra. So when do we do this? So this is about matching demand to the health and care needs of the population through systematic improvement. So we need visibility, we need the visibility of the patients. Now it's one service might have visibility of their patient cohort and no one else can see them. So if you start to share that visibility, that's great. And then the same for the clinicians around other services. Visibility is key. Accessibility. So accessibility to those patients, those services, and also patient records is really, really important. And then a word, I have to say this, Rob, you love this word, don't you? Referability. That no wrong door, that trusted assessor type ability to really start to work in a more mature way, and always coming back to that learning rather than criticizing, and that gives us the ability to adapt capacity and demand both in and out of hours because we understand it better. So where does care coordination, integrated care coordination take place? Most appropriate place for the care. Brilliant when that's at home, particularly with the frail elderly patient, because we know as soon as you start removing them from their home environment to provide care, that's when risk starts to escalate. So let's start with home, talk about community. Pharmacy is an option for a lot of people. Urgent community response, virtual wards. Then we start going towards the more place-based SDEC, urgent treatment centres, diagnostic hubs. So all of these are options that aren't the emergency department. However, actually sometimes the emergency department is the right place, and we mustn't forget that. And so we have to circle back on saying actually the people that end up there are the people that need urgent and emergency care. This isn't about stopping people going who need to be there. And then who? So the most appropriate skill for the patient's needs. So the best integrated care coordinations have multidisciplinary teams. They can be placed in a central location as a hub. They can be remote. But what we need is to build those relationships so people work together across the boundaries, adopting integrated care, working within the governance and risk that is underwritten at system and provider level. So access to lower acuity calls on the ambulance stack, and then with resilience and well-being as a central focus. So I think that for me sums up what it's about and more about what it should feel like and the ethos behind it. So we're going to move on, and Mr. Rob Cole is going to talk about the clinical conversation, because that's a really key component here.
Thank you, Giles. Thumbs up if someone can hear me.
Roger,
yeah,
George.
Beautiful. Lovely, thank you. Lisa, thank you. Mentee's up. So what are the components of an effective clinical conversation? So yeah, if you can start popping them in there, and then I'll move on and we'll talk about it. So at the moment, what we got: patient-centered, respectful, trusting. I agree with all of that, and actually so much more. Trusted assessment, that comes out a lot. So keep throwing these in, and then if you can go to the next slide, please, Lisa. We'll go through it a little bit, I guess. So I guess when I was asked to talk about this, what is a clinical conversation? And I think the first thing to say, this is nothing new for pre-hospital emergency medicine, certainly paramedicine, primary care, whatever. This is stuff we've been doing, since day one. And a lot of people do see this as something new, and I keep reminding people and colleagues that this is what we've done for years, all clinicians, paramedics, other healthcare professionals. We talk to each other. We quite often refer to GPs. Let's be honest, we have a clinical conversation every time we hand over a patient at a hospital, with our nursing staff or medical staff there. So I think the concept of a clinical conversation is nothing new, and it's exactly what people are putting them into, respectful, honest, congruent, non-patronizing, not asking for permission, a clinical discussion with the patient at the heart to agree something. I think that is the general point. I mean, if we look back at more specific conversations, and we had in the ambulance networks, for example, we had trauma networks came in about, 15 years ago. And that was a system not dissimilar to what we're talking about here, where we're asking clinicians to, before you convey a trauma patient, to have a conversation with, this is slightly different, with a group of individuals who are perceived to be possibly more expert, maybe in a different environmental surrounding, so that the human factors are slightly different. Probably they have the benefit of greater information at hand. They may have, you know, Cerner or various other OneNotes or something, so they can offer you more information. And linking a bit into what Joel said, they quite often do have that system command stuff at their fingertips, so they know what's available. They know, you know, who can take your referrals, where their ability is, are they maxed out, are they stretched? And I always say a lot is quite often, you know, you just don't know what you don't know. So there's a bit about you, how would you know to refer somebody to something that you actually don't know exists? So the trauma networks came on board, and that never really bothered anyone. And I think it was because the way it was pitched was, you know, this is an opportunity to have a conversation. Actually, that conversation quite often ended up taking a patient to a different hospital by a different modality, a different timing, which broadly is not dissimilar to where we're talking in from the care coordination clinical conversation. We do exactly the same with hyperacute stroke and stuff. And of course, one of the things we're talking about in this point when we're talking about our clinical conversations is we don't want repetition. If you're holding a clinical conversation for point A, then we don't need to do it again for point B. So I think we've said before, absolutely respectful. It shouldn't be labour. It should be, you know, 3, 4, 5 minutes. Myself and Josie and Giles did quite a bit of audit on clinical conversations, and we listened to hundreds. And actually, the majority of them are less than 3 minutes. And they're a really good, strong clinical conversation. But you can say a lot in 3 or 4 minutes and get your point across when you've got two like-minded clinicians who are trying to agree something. So 3, 4, 5 minutes should be a good clinical conversation. And again, if you look around the country, we've got ambulance crews, and I use ambulance as an example at the moment, spending 90 minutes on scene with patients. There's no need that a clinical conversation would not, I don't see the argument that it delays time on scene. I think quite the opposite. I think a swift clinical conversation can absolutely halve, if not take down even further, the amount of time we spend on scene. And that's obviously safer for our patients and safer for our undifferentiated patients as well. Who should you talk to in a clinical conversation? Well, whoever you need to be fair. So a lot of people will talk about, you know, a senior clinician. I think that's probably broadly right. But we need to talk to someone who's at least like-minded, if not more senior, someone who's probably autonomous and has authority to act upon the information you're given, someone who probably has that information that you could talk to. We use in care coordination quite a lot. We talk to GPs. GPs are brilliant at remote medicine. They're quite risk averse. They're really quite good. They know primary care inside out. And actually, GPs who deal with remote medicine, like GPs, Clinical Advisory Service GPs, are phenomenal. And that's the model, as Giles alluded to, in Norfolk and Waveney. They have an integrated CAS stroke care coordination, or SPOA, whatever today's language is. And that works really, really well. So it can be called a few things. So quite often people call it call before convey. I actually have antibodies to call before convey, and I've made no mistake letting people know this from 2 or 3 years ago, because I think call before convey sounds quite permissive. It sounds like you're asking for permission. It also refers, you're limiting your group of individuals. You're talking about a patient that you are clearly going to convey. But actually, if you look at, again, Norfolk and Waveney, one of our former tier ones, who have really done well from the care coordination point of view, they want to coordinate all patients with health needs. They don't just want to coordinate the patients that you were going to convey. They want to look at all patients within their system and have an opportunity for nursing homes, domiciliary care, primary care, other healthcare professionals. And I think call before convey can actually be a little bit perverse in terms of where the messaging is on that. So I always encourage people to call it an upstream clinical conversation. Clearly failed, because just about everywhere has called it call before convey. But actually, I do think that nomenclature might have to change soon, and I think that's looking at changing in the East for that exact same reason. Should it be mandated? I guess that's always an interesting question. My view is no. I don't think we should mandate stuff, to be fair. I think we should explain the rationale for doing it and try and get people on board. But I do think sometimes that's probably not quite as cut and dry, and there might be a bit of a hybrid between that. So some services before have done a mandate when taking patients from nursing, domiciliary or residential care, to say actually you won't convey these patients unless it's a life-threatening emergency without a clinical conversation. And I always think that if you are going to mandate, then you just need to make sure you can deliver upon what you're mandating. So actually, if you're going to tell somebody to do something, then make it have value. answer the phone quickly, have a really good, respectful clinical conversation, and ensure you have a disposition at the end. Otherwise, you undermine that whole process of mandating something. So I think the jury might be out, but I wouldn't say it's an absolute no, and I wouldn't say it's an absolute yes. I think you could probably discuss. And actually, organisations, trust services, individuals, we're all different. And let's accept our skill levels are different as well. People always talk about paramedics, and I keep reminding them that about 40 to 50% of the workforce aren't paramedics. They're non-qualified, non-autonomous, non-registered clinicians, ranging from an emergency care assistant. So they're not all registered qualified paramedics, and therefore that means people carry risk, and they hold their risk dynamic differently. So what should a clinical conversation not be? Well, I'm just going to say it's the opposite to everything I've just said. So frankly, it really is as simple as that. I have heard some bad clinical conversations. I have heard some where people are deemed to be asking for permission. I've heard rudeness and patronisation, but actually that's the same in any conversation. That simply is just the basic rules for holding a good, respectful conversation, and that shouldn't occur, and I think that should be challenged at all points, to be fair. So second part, I guess, briefly, Giles alluded to case holding. I think case holding is really important. So what is case holding? Well, I guess it's the ability to pass on the clinical liability and responsibility of the patient to another. It's a clinical handoff. I think Paul Devlin used to call this one hashtag handover at home, which is the same sort of process. So I've handed over my patient. And just to put that in a bit of context, what we've seen historically is where ambulance crews would phone a care coordination centre, or formerly maybe a single point of access, and they would do an admin call, and then they would probably spend 20, 30, 40 minutes waiting for someone to call them back, and that answer might then be no or more information. We can't do that. You know, we've got undifferentiated patients, and we need to move things in a more timely fashion. It's not good for the patient, staff, or the wider system. So case holding is the ability to hand over that patient, even regardless of the disposition. So, for example, myself and Giles, if we were a crew, we would have a conversation with a care coordination centre. They would agree, actually, the ED is not right for this patient on this occasion. We're not sure what is right, and their patient may be very complex, multiple issues, and might need a wider range of care coordination. But instead of us having to wait, the patient is frankly, we hand over to the care coordination hub. You know, another clinician will take on the clinical responsibility of that patient, and we will subsequently be released to go out on our jobs. This is just happening as we speak, actually overnight as well in Norfolk and Waveney, and it's just happening really good there because they're starting to care coordinate patients. You know, if you look at some of the elderly and frail, for example, they tend to get left towards the end of the day. And then we end up crews arriving at patients at 7, 8, 9 o'clock at night when, frankly, none of the services are available. So I have to wonder, what is the point of taking somebody who's frail into hospital to receive a service that isn't there by a person who's not working in a bed that they haven't got, when they had all that at home? You know, it was subacute, it was non-emergency needs. So in Norfolk and Waveney now, what you would do with that case is you would phone the care coordination hub, you'd hold a respectful upstream clinical conversation. The CAS GP would take the patient from you and would hold the patient overnight with some welfare calls and some checks. And that patient would be put on a list for the care coordination when it opened the following morning at 8 o'clock to allow them to coordinate that patient. Think of the amount of patients we can prevent being conveyed into hospital out of hours, in the evenings, overnight, in unsafe places where they wouldn't have received any treatment. So, you know, this is the type of stuff that I think we really need to push, really. So I think that's probably where I'm going to end on clinical conversation and case holding, looking at time. And I'm going to hand over, if I may, to the lovely Jenny Sears Brown, please. So thank you.
Thanks, Rob. And going on to my section, we'll be looking at enablers and challenges in the delivery of a responsive ICC model. And we really would value your thoughts on the Menti questions around this, because we're really key that leadership is such a strong driver in the delivery of a functional ICC. So from an enabler perspective, the work that we've done across the country with our systems, what we've found is that when you've got strong system relationships with visible leadership, it is a key driver and a good strategic aim and ambition to deliver a safe, responsive clinical service. And the other thing that really is essential is that through the delivery of a shared ambition and strategic aim, there needs to be a consistent operating model to underpin. So we really do build the trust and the quality in the services that we are delivering out there. Another aspect is looking at system executive buy-in and ownership. And that's really important, where we've got system executives that really believe in ICC and really see the value and the quality of what the patients can get out of that. Another enabler, it's not a showstopper by any shape or form, but it does make life a lot easier when you're looking to develop an ICC or single point of access, is a single stroke community provider footprint around that geographical area. One of the examples that where this really comes into its own is Norfolk and Waveney, where you've got East Mids Ambulance Service, whereas you look at a Staffordshire county footprint, you've got East and West Mids Ambulance Service serving that county, and by default you're going to get diversity in their operating models and what they want out of it. So where you have got single providers in that geographical footprint, that does help us out. Another aspect for enabling is IT capability, and I know it's the bane of many people's lives is in it lack of interoperability. But if where we've got good IT interoperability with a overview of that system demanding capacity in a real-time live information way, where systems can make decisions literally on a minute-to-minute basis, and looking at how we can start leveling out that demand to mitigate the risk is really important and really a key enabler. The other thing around the digital side of things is that that visibility of shared patient records, the ability to look into direct bookings, along with the IT governance infrastructure that's underpinning the processes that are out there. So it's not too restrictive, and it adapts to multi-organisational working to deliver that patient care. Another key enabler, as I'm sure you're not going to be surprised at, is the adoption of a learning systems approach that Giles alluded to, and underpinning that is the attitude, the behaviour and the culture of the organisations and the wider system, really putting people at the middle of that that ethos and making them feel valued and heard. And again, it's that top down, bottom up approach to owning that single point of access ICC approach. Another key area is the use of the data, both quantitatively and qualitatively. Again, this looks at developing those sustainable operating models to meet the population health needs, not only today, but in 5, 10, 20 years' time. Another key enabler is looking at how you're using your workforce. It's our most precious commodity, and having that system ownership of the workforce to develop them, to enhance the skill sets, to promote retention, absolutely vitally important. And another key enabler is the system collaboratively owning the risk. And that joint risk ownership is absolutely key. So often do we see that the ambulance service and the ED are the default positions on this, where that is where our biggest clinical risk is. So looking down now at the challenges are pretty much everything in that we've said that we haven't got with the enablers. Some key things for the challenges is that we're finding is a loss of organisational memory that's coming through with the reconfiguration of the ICBs. We have lost a lot of organisational historical memory. Some of the challenges around the historical commissioning as well that have been associated with historical governance arrangements. the misalignment of organisational policies, strategic vision and operating models within the systems across an ICB is also a key challenge that we find. But that said, some of the challenges can be turned around. It's not easy, but with a will and a way, we can turn those challenges around. So I'm going to now hand over to Patrick, who's going to give us a little gallop through the guidance and principles. And so, Patrick, over to yourself.
Thanks, Jen. Hopefully everybody can hear me okay. Someone just give me a thumbs up. If I turn my camera off, it's just Wi-Fi and buffering issues. So as we've been navigating through the slides, we've seen where some of the focus is around for CareCo and single point of access. But it's really important that we acknowledge there's lots of great work going on in systems. We've got ambulance trusts that are pretty much deflecting about 30% under hear and treat and see and treat. CAS, clinical CAS 111, both run by ambulance and some not, who are also doing great work and deflecting a lot of patients through their clinical advice service. But despite all that hard work, there are still hundreds, if not thousands, of patients every day that still go through that but end up being conveyed to an ED. And as we heard from Giles earlier, we've got our little statement that this is about providing a clinical conversation that safely connects the patient to the right care or right team for their needs, independently of where they have. Apologies, folks. Are you still hearing me? My laptop's having a moment.
Yeah, we like
now.
Patrick.
Yeah. It just had a little buffer. Yeah, so that little statement we have around the clinical conversation. But taking it a little bit further, to be helpful in systems for all of us that are navigating our systems and the places that we work in. One of the things we want to try and instill across systems is to agree behind a set of principles. And by adopting key principles, it navigates around those competing interests from different providers, as well as the competing interests from different teams and specialities within hospital. Some of these key principles have a focus that systems can work with collaboratively that totally adheres to that principle that we said above, that clinical conversation. One example of this that's coming up of late, and the North East system are adopting this across the whole region, is that they're going to adopt a principle of patients around nursing homes, that if a paramedic goes on scene and tries to do their traditional historical see and treat on scene but cannot get that patient into any of the agreed pathways, that they are then going to adopt a principle of what we call clinical validation of that ED conveyance, and they're able to call a senior clinician, ideally a geriatrician or maybe a medic in SDEC or a consultant in ED would do it out of hours, have that upstreamed clinical conversation, and as a multidisciplinary team in real time can make the best decision in the best interest of that patient of where they've to go, if it's direct access into maybe a virtual ward, UCR, if there's an SDEC provision, or if they could be kept in the nursing home and treated there. And these principles help the system all agree a collective why, instead of, as we know, they all focus on their competing interests. Next slide, please. On the next slide, the team, the navigation and access team, working well with some of the national colleagues, have pulled together a number of documents, and some of the wider ECIST colleagues have given their input into this. All of these resources go into details around some of the principles, go into the details around some of the logistics around CareCo, single point of access, what does it mean to casehold, etc. These are all available on all of our SharePoint, collaborative drives, etc. Several of the documents are live. You can download them, but the reason we went down the route of them being live is that if something changes, like we've seen today, the name SPORE, ICC, it keeps flipping backwards and forwards, so we're able to update the document in real time to avoid systems going down the route of having the wrong information, and that's the only reason. But I would encourage you to read some of the documents. It's really helpful in terms of terminology. We love acronyms in the NHS, and if we can bring ourselves up to speed on some of the call before convey language and what it actually means. Systems will come up with their own terms. They're already starting to do that, but they're brilliant resources. I've been doing this for a good number of years, but I still go back to some of these documents just to refresh what it means to me. And it's really helpful, as we've seen on site. Some of us were in Warrington, where we can, because of what we've read in these documents, we can see things that are being done. Warrington are doing a particular piece of work around frailty in care homes, and they're already on the route to doing this. So it just helps align the two and show where the knowledge from what we want to achieve is already being done within systems. That's it from me. Over to Liz.
Sorry, my computer decided to hesitate for a moment there. So thanks everyone for taking us through there. So quite a lot that we've talked about in terms of the themes there. So this is a piece of work that's growing in momentum, which is fantastic. And it's a great opportunity to think about how we're able to nudge and improve some of those discussions to enable better navigation for patients through what can sometimes be a very complex landscape, and to reduce the risk for some of those people that may be not getting the best deal at the moment. I think as ECIST, we need to think about how we might be able to get involved in those different bits around those enablers that Jen was talking around in terms of, the ICB, leadership, governance, how to have a good clinical conversation, and that kind of stuff. There's evidence that's growing all the time because this is quite new. So we will continue to build that, and it's important that we keep that sort of learning culture around the development of this service. And essential to its success, just like with everything else, is having good, strong leadership and good clinical and patient-centric conversations. I'm going to leave it there and hand over to the experts to answer any difficult questions. And thank you to those who have already started to evaluate today. So please continue to evaluate. And we have got a little bit of time if anybody would like to ask any questions.
Thank you, everyone. Any questions from anyone? Jyoti?
Not questions, but just to say that this area is one place where there is not a lot of evidence. So it is really up to us to build that evidence as much as possible. So any nuggets from anywhere, please, put it somewhere, because I do believe this is one of the transformational pieces of work. So yeah. So any evidence we can collect, Norfolk doing that stuff, and systematically collect the evidence, it'll be useful.
Thanks, Jyoti. Lisa?
Thanks, Lee. Rob K, just 10-second warning, I'm putting you on the spot here, but I just thought, I know I've been a little bit involved in the background, sort of helping administratively. I think it would be really helpful for the other heads of improvement just to hear about some of the conversations that are happening between our team and the National IUEC team and policy team around next steps on some of this stuff, and the fact that the toolkit's going to get issued with the winter letter and that kind of thing. So if you could just maybe give us all a quick 5 minutes update on that, I think everybody would find that quite useful. Yeah, no, of course. It's a fascinating space where people recognise the need for this in the depths of winter. But of course, when we come out of winter, perhaps the motivation for having solutions to respond to the emerging tales of risk and harm are less well felt across the system. So we get an ebb and flow of the need for this. But as we head into winter, there's a broad recognition. The guidance that has come out, and I think Giles has helpfully put in the chat box there, describes care coordination as something that should be picked up by systems as we head into winter. We've helpfully steered them towards two levels of that. One is that foundation level where they've got the nuts and bolts in place, if you like. They've got the pathways that are accessible. They're improving the visibility and accessibility, get my teeth in, and the referability. But what they perhaps don't do then is take it to the next level, which is identify the learning, identify the gaps in services,
recognize what the demand and capacity looks like when we start to differentiate it from the when the patient presents. Now, Rob mentioned it a moment ago, that patients may present late in the system. The demand itself may have happened at 8 o'clock in the morning, yet the patient, it might be a frail patient presenting to a frailty team at 6 or 7 o'clock in the evening. So there is something about what this enables the system to do in terms of its learning. And that's the next level that we're keen to help systems into. As a result, there's a number of conversations going on between the national team and the regional teams, and then of course between the regional teams and the various ICSs. So what it has looked like over the last month certainly is an exercise in assurance between the regions and the ICSs in terms of their progress towards the foundation levels. What we've helpfully offered ourselves forward for is to take on what would be the improvement conversation to help them get into what is that the learning system. Now, it could be argued that if everything was working hunky-dory within a system, you wouldn't need any type of care coordination. You know, everything would be managing itself quite well. However, we know in the depths of winter, you'll have category 3 and 4 response times, which are extraordinary, over 24 hours. You may indeed have category 2 response times, which have grown beyond what we would see as reasonable response times to those patients. You will also get people being upgraded within that profile as well. So from a 3 to a 2 or a 4 to a 2 as a result of that. If you don't have a mechanism for managing that risk in the system, care coordination is your easiest, perhaps most accessible way of truncating the risks and responding to those risks in the system across multiple providers. And I'll say it again around the agnostic position of providers, or certainly our approach to this. And it could be perceived that we're just prescribing a bit of teamwork in the systems. But we think it's something more than that. We think it's something deeply about patient harm and patient safety, and how we can respond to that to connect those patients up with the care that they need, and rather than let them languish at the end of a response time, which we will see manifested in ambulance handover delays and all sorts of other things. So the national conversation is about assurance to foundation level, if you like, and we've offered our support for systems who then want to take it to what is that learning system level to help embed this and take it to the next phase. Typically, a lot of the ICSs are really strapped for cash, so there comes a conversation about the evaluation and providing good evidence that this is the right thing in terms of how it responds to the risk within a system. But there's a lot of this will play out over the course of the next few months, and I think we're in a good position to be able to respond to that, particularly with our tier 1 systems where most of our work has taken place so far. I don't know if that helps, Lisa, but does that go some way to answering the question?
Yeah, absolutely, Rob. I think it's just, it's always helpful because there's always little pockets of conversations happening, and the beauty of having these sessions that we've got in place now, being Lunch and Learns, is it gives everybody the opportunity to hear the same message from the same people at the same time. So yeah, that was really helpful. Thank you.
Well, can I just put out one other tiny little thing there? It's a plea to other people. It's often being perceived that this is held within a small group of people within ECIST, and people like Erica, Liz, Nick Holding, they're taking it to a more broader audience now, and of course it's starting to become mainstream conversation. But I think our overall aim is for it to become mainstream conversations between ECIST and our systems as we move forward, recognizing of course all of the pressures which come along with our targeted winter offer and our tier 1 systems that we've got at the moment.
Thanks, Rob. I'm going to take the chair prerogative and ask my own question. Is there any work going on around? Actually, I'll put some context to it. So when I moved down to Petersfield, I was quite surprised how much my GP uses the NHS app and how far ahead I think it is of a lot of the country. I was wondering, is there any merit or is there any conversations going on with trying to link some of this work to the NHS app? I appreciate there is a massive variability in usage across the country, but I know accessing services and directing services through the NHS app for our GP is becoming more and more prevalent, and that's almost a cost neutral way of beginning to open these conversations. I know it's not going to have the same, it's reducing a much bigger idea to a very small piece. But I just wonder whether there's stuff worth getting to that conversation quite early.
Yeah, I think Rob's got his hand up to answer that. I'm not sure.
Yeah, I'm happy to. I mean, it's a really good question, Lee, if I'm honest. So I guess there's a couple of nuances here. So the care coordination that we probably tend to discuss more often is more about healthcare professional into other healthcare professional. So when we look at so the CAS, clinical advisory service, is more about patients. That's the patient connection into the system, and the care coordination that we refer to predominantly is more about healthcare professionals. So in terms of the NHS app, no, for that one specifically. In terms of app integration, they are actually looking at that already. We do some work with some digital teams, also looking at headset technology, virtual technologies, virtual reality technologies, and AI, because I think all of these things have their, have their merits. We're here on a meeting today, are we not? All over the country, and the amount of times I see people have a pop at digitalization, but they have an argument on the very model that they're having the argument on, so that they're slagging off the same thing that they're actually on. We do Teams really well, and actually I think it's really underutilized. So if you look in North London, the Reach model, they use Teams routinely for doing part of their care coordination, and they also use an app as well. Funnily enough, they're one of the first ones to do that. So I think the app stuff is really interesting to develop more. I think from a patient-centric point of view, of course, there is the 111 online, which is massive. I think Giles went through some of this recently, and the amount of contacts on 111 online are, tens and tens and tens of thousands. So I think in the next year or 2 years, I think it's probably a point we could really see that change. And I can see clinicians being able to utilize apps to do some wider care coordination connecting. I think it's the route of travel we should absolutely be going.
Yeah, I think thanks. That's really, really helpful. I think where I was, just to sort of elaborate, I suppose, where I was thinking with the NHS app is obviously it's GP led and based. And so although, I'm accessing it, your GPs will have to understand your pathways to be able to use the app. And so almost you're then educating a key group to take off some of that demand from other areas. Sorry, Patrick.
Yeah, I agree. It's a brilliant question, Lee. And it's almost exactly what you just reiterated is what I was going to say. So it's where CareCo sits. So you've got a multidisciplinary team. We all know that GPs are sometimes faced with patients that really shouldn't be in the GP. They're there by default. They should be somewhere else. And it's about the GP then, either our patients use the app to access the GP and then the GP accesses the CareCo. It's got to go both ways. It's good, high functioning CareCo models allow GPs to access it, so they would come from the app. But it's also, when you bring a multidisciplinary team together, one of the best things that you see in real time during the pilots when they're in the room is when it's a community therapist. I used to call it the little black book. I took a community therapist in an ambulance car years ago. They could keep patients at home with a little black book of contacts that they knew individual pathways. That's what's missing. We need an app at that level between clinicians. Ambulance has it in a form of Pathfinder, which is a kind of an app that ambulance clinicians can access NHS services. But yeah, the app is a brilliant way to feed into CareCo from the GP.
Jyoti?
Quick point on the same thing. I think it's a really good idea. The thing is, it's most useful in frail older patients. That frail older pathway really is which you can maximize the benefit of this. And I just wonder how many of the frail older patients actually are tech savvy. But it will change. There's no doubt they'll be tech savvy. But if they can actually access the community services directly rather than call the 999 or 111, it will be much better. So if we can make community services 24/7 and they're able to access that will be much better than the CareCo, I would have thought, because that's where most of the work will be.
Yeah.
Do you agree? Or
yeah, no.
And apparently it is there in the 5-year strategy for the single point of access group. It is about making community services 24/7.
Yeah, I think it's really interesting, isn't it? The digital literacy of people. Because I think even what was it, about 15 years ago we did this piece of work, and 98% of our patients within our inpatient unit at the time had accessed the website, or carers had accessed the website before they went there. So I think there's more people accessing these things than I think that we think. But you're right, is that level of interaction, access versus interacting, actually booking and doing things is very, very different, isn't it?
Yeah.
Where we're coming up towards the end, is there any sort of final questions from anybody? Rob, was expecting you to ask some questions.
Yeah, well, I was just wondering if people want to come along. There's an open invite to our team meeting for people to come along and get involved with this type of work. And if we just take the points that we've just heard together, this is almost like a staging post for systems and partners within systems working together. And we've often said that ICC may not be the end result, but if it gets people talking about what can be different within a system and how systems can be redesigned in a way that better suits the demand and the case mix that exists within them, then of course this is a helpful adjunct to that conversation moving forward. Of course, we're not going to, in one fell swoop, upset the way in which services are commissioned right across the board, but we have to get them being able to concentrate and come and coalesce around the risk and harm that does exist within systems. And this gives us almost like a staging point to some of those more nirvana 5-year approaches that perhaps we've heard in the last few minutes. But it's an important step in that building together of the relationships, which I think Rob mentioned earlier on, and the trust within providers. So I think it's a great opportunity for us to come and just describe a little bit of this about colleagues, but we'd like to get more and more people involved with that over time, so it just doesn't seem to be held by a few people. We want to bring this into the hands of the many, as a previous leader once said.
Brilliant. Thanks, Rob. And thanks for the invite for everyone. Just perfect. Just to remind everyone, Chris, there's a survey link in the chat box. Very much around sort of lunch and learns, what can we do better, what's working well, all the rest of it. So please do take a few minutes to have a look at those. We are pulling it all together and helping to shape it going forward. And so with 2 minutes to spare, I will say goodbye and thanks everyone. Great to see you all this afternoon and have a great weekend.